Hello and welcome to Season 2 of Keep It Science. We are back and with a bit of a twist. This time we are shining a light on rare diseases, from insights from biotech leaders and specialist clinicians to personal stories from the people impacted the most. Now, we say rare, but over 300 million people live with rare diseases. That's roughly about 1 in 20 people face years of diagnostic journeys with limited treatment options and struggle with diseases for the rest of their lives due to a lack of a cure.
I'm Dr. Elisabeth Kugler, and for me this season is incredibly personal. I have myself a rare autoimmune disease, which includes scleroderma, dermatomyositis, and secondary Raynaud's, which is called an overlap disease. And so as a scientist and rare disease patient, I hope to contribute insights from both of these worlds in this season.
And I'm Dr. Nick Gorn, and together with Elisabeth and a variety of guests, we'll explore everything in rare diseases, the science, the stories, the struggles, and most importantly, these exciting breakthroughs that we're seeing every single day.
Hello and welcome to this special episode with Dr. Jesus Zurdo, the director of our Biosciences, leukemia survivor and patient advocate. Jesus is also non-executive director at Telomere Therapeutics and a member of the expert jury at the European Innovation Council Accelerator Programme. We actually hosted Jesus in episode 4 together with Sue Farrington, and there was just so much that we learned from him that we thought we'd bring him back in for some extra additional patient insights. So in this episode, we will talk with him about the impact of medication and the side effects on patients. We cover questions such as what does off-label use mean? How can we define effective treatment? And why the quality of life has to be at the very center of everything. So we very much hope that you enjoy this extra special episode. I want to talk about treatment challenges because I know that, as I said, leukemia and rheumatology are very different, but there are a few similarities, especially also in terms of, for example, off-label use, which is meant to use a licensed medicine outside the terms of its marketing authorizations. For example, aspirin is for pain relief, but it's also used to prevent stroke. And for example, we then also have label expansion, which is a process of submitting new data to extend a treatment license to cover additional conditions. So, for example, Viagra was developed to treat high blood pressure and angina, which is chest pain. And then it was also seen to improve erectile dysfunction. And then that's kind of what it was extended to. But so you're an absolute expert in the field. And so maybe you can talk with us about really this challenge of why is it so difficult to use medications off label or maybe even get label expansion, and why would it be so beneficial for many patients?
Oh gosh. Well, I'm not such an expert. I mean, I understand some bits. Unfortunately, I'm not an expert, but I think my experience of therapeutic development is quite rigid, and there's a reason for it. You need to prove that you are addressing a medical need, and then that your treatment is efficacious in addressing that medical need, that is meeting some endpoints, efficacy in an objective way. It's not like I feel like, if I twist the data, it has to be clear, but also, and primarily, is safe, is not causing harm to the patient. And this is what it gets tricky, because when you treat different diseases, the resilience of a patient to a treatment might not be the same. It's not the same, a patient that is immunocompromised and receives a treatment, then it might be very sensitive to, infection or other complications than a patient that has an immune system that is very reactive. So it works both ways. I mean, if you have an overactivated immune system, you can experience side effects that a person that is immunosuppressed would never. So I think that's the challenge, probably because the way medicines have historically been developed has been very structured. It's like, okay, you do your safety, fine, your doses, fine. You understand there's a population of patients I'm going to treat. I see efficacy, and then I get approval. And traditionally, what the industry did was, now that I got approval for this condition, I'm going to go into this other condition, which is related, or this patient population that is larger, it involves higher risk and investment from a development perspective. But because now I know it's safe and it's efficacious, I can afford the investment. So that's how industry has approached it. However, the problem is that the financial economic model behind it makes sometimes unattractive developing the use of some of these treatments in other applications. And this happens all the time. And I mean, I'm glad you raised these examples of off-label. As far as I know, maybe I had so many different medicines and treatments that I didn't do an exhaustive analysis, but there are two that I know that were used off-label. And one, the most important one, is Alemtuzumab. It's an antibody that was originally developed here near to where I live in Cambridge, Campath. And this antibody was originally developed to treat CLL, chronic lymphoblastic leukemia. And it was launched in the US and in Europe, or the other way around, and eventually was discontinued because it was not, financially was not that attractive. But then it was approved or authorized to be used in multiple sclerosis. And it's an interesting antibody because it modulates your immune system. It targets, I think it's CD52. It's a protein that is present in T cells and in B cells. And basically, it suppresses your immune system. It kills these cells. And this can have multiple applications. And you were talking about we have completely different diseases, but you see this medicine can be used to treat an autoimmune disease. And actually, I think people are trying to use it in myasthenia gravis. But also you can use it to condition the patient that is receiving a stem cell transplant. In my case, it was used to suppress what it was left of my immune system so it would not kill the stem cells that came from the donor, but also because the antibodies remain in your bloodstream for a long period of time, it helps modulating the cells that come from the donor, because the cells that come from the donor have stem cells, but have T cells, B cells, etc. So what it does is eliminates or controls those cells, so the stem cells can engraft, and also by modulating the T cells, it reduces the chances of a GVHD. So it has this combined effect, and actually is proven to be quite effective. And I think the UK was pioneer in using Alemtuzumab for stem cell transplants. So to me, this is brilliant because it's a nice way of looking for potential uses of medicine, and this because there's lots of knowledge generated over the years of how this antibody works in patients. Then you could start designing. Clinicians can start designing. Okay, what if we use it in this case? I know, for example, it's used also in solid organ transplantation, again to minimize the response of the recipient immune system against the organ, and it increases the chance of successful transplants. Even some people say that it could be used in HIV. So this, to me, is really encouraging to see that actually you can leverage the knowledge and use an existing medicine to treat all the symptoms, to treat all the diseases. You don't need to come with, from scratch and developing something new. The other, I received was rituximab, and this is because all this is being developed for specific types of cancer. In some cases, it is seen that improves the outcomes of a patient. It's understood partially, but it's not clear why, because it depends very much on what kind of cells you have or what kind of makeup your cancer has. Is because it's a well-tolerated treatment, often is given, and is not too expensive, is given as an insurance policy. Well, if it can improve the chances of a good outcome, so why not? And I think hopefully in the end, once our diagnostics and our testing system improve, we will be able to really be more precise about how we use these different treatments. But to me, the off-label is clearly an essential element that is here is here to stay. It brings up quite important questions about how we develop medicines, but also because you cannot just buy, in this case, Alemtuzumab, Lentrada, because it's for MS, and then repurpose it. There are how you manufacture, what are the controls systems you need to put in place. It brings up quite a lot of questions. It's a commercial product effectively, so how is it, who is in charge of all this? And I know in the UK, NHS has a number of agreements to ensure that these medicines are available. Other countries don't have that in place. So yeah, it's not a trivial question, unfortunately.
No, absolutely. And so rituximab, I'm myself on it,
All right,
for
there you go.
also immune condition. But
Yeah.
also I think you brought up costs, and that's quite interesting because so I just did a quick Google search, and so the cost for like one course of rituximab is about £10,000 for the NHS.
Mm-hmm.
I think that's also something that a lot of people don't really see, like the
Mm-hmm.
cost of these drugs, as
Yeah.
you mentioned, play such a huge role. But then it's not just the cost, but also all the side effects, obviously. And there's so much kind of maintenance drugs that you take in addition to like antibody treatments like rituximab. But yeah, I think it's really important to say like they might be kind of primarily applied, for example, for autoimmune disease like rituximab, but then are also applicable for leukemia, which is really, really important. But also so as a kind of side example. So for example, for me, I do take like a low dose of Viagra to open up blood vessels
Yeah.
to treat Raynaud's. And I think,
Mm.
that's something that the first time I heard it, I was like, haha, what a joke, right? But actually I do, and it works really well. But also it's quite expensive if you think about, the cost of Viagra kind of, and that's also like a maintenance drug. So it's adding up costs, which is not great for the healthcare system. But I think also one thing that you mentioned on is like the kind of effective treatment. And I like that you say it's not just about like the primary outcome, but so many other things that are beyond the scientific and clinical definition. So maybe kind of coming back to that, what in your eyes would be a nice definition for like effective treatment?
Oh, I'm going back now to involving patients. I am one patient with a point of view, and I appreciate is unique. And if you were suffering the same disease, you have a unique perspective. So I think it's important that what is effective means different things for different people. And this is what you need to be careful when you define the outcomes you are aiming for. But in my case, again, I keep challenging people in the scientific community when we talk about new treatments, and we are living through fantastic times. And generally, I think for medicine and for oncology, for autoimmune disease, I see. At the end of our road is probably strong because I don't believe in cures, and we talked about this, but a good treatments that really allow patients to live a pretty good quality of life. But I think it's important that we define what is important. There you go. It's essential we define what is important to patients. In the case of cancer, in my case, we are obsessed about life versus death. And I think death is a big challenge in our culture. For me, now after being ill, life is important, but not at any cost. For me, living in a bedridden is not quality. And then extending my lifespan by a few months or a year, if I need to be bedridden, I need to have round-the-clock support. Is it really worth? And this, I'm a bit brutal. This is I know, very sensitive topic, and people will take it different ways. Not just the patient, the families. These are big conversations. I had myself these conversations with my family, and we agreed what was agreeable and what was not. But for me, quality is essential. What is quality? For me, quality means I can be functional. Now, functional means that I can carry on what I love about my work. I mean, it's not the same, and I need to accept my limitations, but be able to carry on a professional activity, be able to meet with my friends, be able to do some basic exercise, to have social interactions, that and to be independent, to be able to, we were talking about do the shopping, cooking. I love cooking. That's something that for me is so important. And if that is taken into consideration, of course, and we can ensure that the outcomes allow the patient to do that, that's fantastic. But I want to give you an example, and this is a big, not fight, I mean, argument I have with scientists when we talk about cell therapies and gene therapies for cancer and other treatments. And there's all this excitement about, these new CAR Ts or this in vivo, what it involves. And people have these arguments about, oh, this is going to be so much better because it can bring down costs. I necessarily agree with that. But I find that because they are not patients, they miss, for me, one of the big elements. And is that some of these treatments, particularly, just an example, in vivo cell therapy, for the first time enables the patient to receive this treatment without having to be immunosuppressed, immunodepleted, lymphodepletion, or condition they used to call it's the real term is myeloablation. Basically, you eliminate your immune cells to allow this CAR Ts to engraft. And this is something that people just tiptoe around. They don't really look at the impact to the patient. When you are receiving lymphodepletion, then you are more prone to have infections. You have a higher risk of having adverse reactions, cytokine release syndrome, ICANS in the case of CAR Ts, in the case of stem cell therapy, the GVHD. And the intensity of GVHD is linked to the lymphodepletion. But there are other issues that your liver, your kidneys, your lungs can be damaged because of these treatments. So it's not trivial that suddenly this new treatment eliminates that. To me, is so important. Is wow, as a patient, please, can we have that? And also be able to bring some of these treatments earlier on, so you can start considering eliminating the nasty excessive chemo treatments you need to suffer. Now, suddenly, the quality of life perspective, is embedded. Is so much better. So, of course, survival is increased, etc. But if some of these modifications in treatment can guarantee a so much better quality of life for the patient, and I think this is what is somehow missed in the conversation when people talk about the efficacy of these treatments, is everything is survival. Yes, survival is important, but survival in how? And to me, survival with this improved quality of life is a dream come true. It's the whole package. So this is, to me, so important. But also, and addressing now chronic conditions when you need to be basically receiving treatment for life. Equality is essential. I mean, otherwise, what is the point? And it goes to the point you were raising before. The cost of these treatments is not trivial. But then you need to put a value to quality of life. What does it mean? If a patient can work, that means that the cost to society is reduced. So you can afford to pay more for the treatment because actually it's costing less to the society. If the patient doesn't need a care around the clock, that means that the value of the treatment is so much higher. So I think it's important that in the equation, when these things, the CALIs or whatever, are calculated, is not just survival and be bedridden or not, which is a multiplier 0.5. Your bedridden is 0.5. Okay, whatever. It's more subtle, is being able to work. You don't need support, you don't need benefits, be able to be independent, you don't need a carer, suddenly the cost effectiveness changes completely. And I'm a bit, going a bit around this, but I think all these elements, understanding what is important, what is quality of life, and what are the implications for society, but also how this correlates with the cost and the value of a treatment is important. And I think we're going in the right direction, but it's still early days. Sometimes some of the conversations I have is too basic to, this many years of survival, whatever. Okay.
Yeah, no, there's so many aspects that are falling into this. And I think that's the things that a lot of people unfortunately don't see, like the impact on work or, being able to do your own shopping and things like that. I know for me, one of the worst things is that because of my Raynaud's, half the time I can't feel my legs or my arms. So I can't drive. So I need my partner to drive me basically to every medical appointment, which is a lot of them. And I know for me that is something that people don't think about. And it might be like a little thing to them, but if you live with it, it's a huge, huge thing, right? And again, like one really important thing is obviously all this staff that also supports us other than doctors, right? I think, like you say, nurses are so important, all the staff, all the scientists are really important. But I also, I always find when you go back to the same ward, because after some time, people very well, it's really nice and comforting to have that relationship with staff and, have your, little personal relationships with each one of them, because they know you and they know sometimes you're worse and sometimes you really don't want to talk, and sometimes you're really good and sometimes you want a bit of a chat, and it's really nice to have that relationship with the staff as well. But there's so many gold nuggets that I could be talking with you about for ages, Jesus, but unfortunately we are running out of time. So I have to thank you so much for joining us, and it was an absolute pleasure. Thank you so much for joining us. And so to round up, you have now heard from Dr. Jesus Zurdo from Ara Biosciences and Telomere Therapeutics. So if you want to learn more, you can head to their websites and find them on social media. We will make sure to link them across all the different accounts and platforms. And we will make sure that we have all the episode details for you at hand. And so to our listeners, thank you so much for tuning in to this episode. And make sure to stay tuned in for our next episode, which is coming soon. So thank you so much. Bye for now.
Thank you.
This podcast was produced by Keep It Science, a collaboration between Acorn Scientific Marketing and Zeke's Art for Geeks, two award-winning science communication and marketing agencies based in the UK. If you enjoyed the episode and you're thinking about launching your own podcast, whether it's to share some expert insights, tell your company's story, or build market presence, we'd absolutely love to help you create a podcast with outstanding science and production quality.
So drop us a line at keepitscience@gmail.com, find us on LinkedIn, and if nothing else, keep it science.